Vaginal bleeding during pregnancy places women at increased risk of spontaneous abortion. Etiologies for threatened and spontaneous abortions have been well studied, but there is little information on intertwin membrane hemorrhage. Therefore, we would like to present a case of intertwin membrane hemorrhage with spontaneous resolution, an obstetric phenomenon that is not well described in the literature. Thus, the implications of an intertwin membrane hemorrhage are not well understood, and management recommendations can be difficult to offer. Similar to the pathophysiology of an abruption, a collection of blood in the uterus would increase the patient's risk of preterm labor or premature rupture of membranes due to the presence of thrombin. Furthermore, the underlying uteroplacental pathology predisposes the patient to developing preeclampsia, oligohydramnios, and intrauterine growth restriction. Our patient is a 33-year-old G1 with dichorionic diamniotic gestation who experienced first trimester vaginal bleeding and subsequent visualization and resolution of an intertwin membrane hemorrhage. She presented initially with first trimester vaginal bleeding, and ultrasound imaging of the pregnancy was reassuring. A normal dividing membrane was appreciated. However, when she arrived several weeks later for her nuchal translucency, an intertwin membrane hemorrhage running the length of the dividing membranes and measuring 15 millimeters was seen. Follow-up ultrasound 2 weeks later showed the hematoma had been reabsorbed. Differential diagnoses for the intertwin membrane hemorrhage included a circumvallate placenta, an amniotic band, uterine syncae, uterine congenital abnormalities, or membranes from a vanishing twin. This irregularly thickened 15 millimeter dividing membrane was not a normal variant, as the vast majority of dichorionic twins show thickness between 1.9 to 3.6 millimeters. Due to the increased thickness, echogenicity, and relative homogeneity of the region in question, as well as the transient nature, all the aforementioned possibilities are less likely than simply a hemorrhage collecting between the twins' amniotic borders. The patient had an otherwise normal pregnancy until the third trimester, when she developed preeclampsia with severe features and elected for a primary cesarean section at 35 weeks and 5 days. That was complicated by a postpartum hemorrhage intraoperatively due to an estimated blood loss of 1 liter. Otherwise, the birth was uneventful, and twin A weighed 2,500 grams with APGARs 8 and 8, while twin B weighed 2,300 grams with APGARs 5, 7, and 8. On gross examination, the placenta did not demonstrate any clot between the twins' amnions. Nevertheless, per the pathology report, on the membrane between placenta and A and B existed an area of confluent subchorionic fibrin deposition that measured 45 by 40 millimeters in diameter. She was discharged on postoperative day 5 after receiving 24 hours of postpartum magnesium and being transfused 2 units of packed red blood cells due to symptomatic postoperative anemia. The infants accompanied her home. Several teaching points from this case include, firstly, that the incidence of intertwin membrane hemorrhage is difficult to predict, especially if it can spontaneously resolve. It may be more commonplace than anticipated, particularly with the increasing rate of multifetal gestations. Secondly, in theory, an intertwin membrane hemorrhage increases the patient's risk of preterm labor, preterm pre-labor rupture of membranes, oligohydramnios, intrauterine growth restriction, and preeclampsia. Lastly, based on this case, the best management course for an intertwin membrane hemorrhage is conservative management with close observation in the event that the patient develops the aforementioned complications.